Hi, everyone. Welcome. Thank you for joining. We'll get started in a minute here. Okay, we'll go ahead and get started. Hello and malo'olele, everyone. Thank you for joining us today and welcome. I first want to acknowledge the indigenous Anacostan and Piscataway lands I'm zooming in from, also known as Washington, D.C. My name is Lena Weepy, and I serve as the Director of National Policy and Advocacy for Empowering Pacific Islander Communities, or EPIC. EPIC is one of 46 national Asian American, Native Hawaiian, and Pacific Islander organizations in the National Council for Asian Pacific Americans Coalition. I'm part of NCAPA's policy team, and I help manage the Health and Immigration Policy Committees. I'd like to acknowledge our Health Committee co-chairs, Crystal Caner with the National Asian American Pacific Islander Mental Health Association, and Adam Carbolito with the Association of Asian Pacific Community Health Organizations, who couldn't be here today but helped drive our committee's work. NCAPA strives for equity and justice by organizing our diverse strengths to influence policy and shape public narratives. April is National Minority Health Month, a time to uplift health-related issues impacting racial and ethnic minority communities, including AA and HPIs. This briefing comes as care has become increasingly a top priority for our communities, yet the accessibility of it is decreasing, leaving families with less preventative care or no care at all. Seeking care is about improving our quality of life, not making it worse. One thing is clear: we care deeply about the well-being of our elders, our parents, our youth, our women, our bodies, our disabled communities, our queer and trans communities, our immigrant communities, and our land. We continue to show up because we care, and our speakers will share more how they've been bridging gaps in care through policy, equity, and access. NCAPA's Health Committee is hosting today's briefing, and you'll hear from members who will share perspectives, expertise, and experiences that span data, misinformation, health equity, gender affirming care, reproductive health, and relief efforts in the wake of natural disasters. We'll also hear some insights from the Hill, and we thank Representative Judy Chu, a champion for AA and HPI health, for sending her remarks via video, which we will play in a bit. We'll share member resources throughout the briefing, as well as a fact sheet that we've developed that can be found on the NCAPA website. This session is being recorded. Please keep your mic muted so our speakers can be heard clearly, and use the chat for any questions or comments you might have, and we'll make sure to follow up. I will now pass it to NCAPA's Policy Council, my colleague Ravi, who will share some policy updates with the federal state of play.
Thanks, Sina. Yes, my name is Ravi Raj. I'm Policy Counsel with NCAPA. Here to just give you some federal updates on what the healthcare state of play has been like these last year and 4 months with the Trump administration and Republican Congress. I think we need to go forward a few slides here. Great. So at the end of last year, the Affordable Care Act subsidies expired. These have been extensions of emergency subsidies from COVID, and there was no deal to extend them. This is going to hurt working families. One, there's less help for low-income individuals to buy health insurance. And when there's a smaller base of individuals buying insurance, that increases premiums for everybody. So premiums since that happened have increased an average of 26%, with some seeing way higher increases. And as a result, while it's still early, at least 9% of people have dropped their ACA plan, again, narrowing that group of insurance purchasers. And an estimated 2.2 million fewer will be insured in 2026 than in 2025, according to the Congressional Budget Office. Uh, in early January of this year, President Trump released his Great Healthcare Plan framework. It included goals like lower drug prices, lower insurance premiums, hold insurance companies accountable, and maximize price transparency. But this is simply a framework. There hasn't been any follow-up legislation on this. So really, the devil's going to be in the details of how Congress plans to implement these and keep prices low for individuals while providing good coverage. Um, the Trump administration has also made changes to their vaccine advisory board and to vaccine schedules, making some of those vaccines optional rather than mandatory, and allowing some who are more skeptical of the current vaccine schedule to be placed on that advisory board. So we're going to see a change in, you know, early childhood health care, as well as a change to community health around these diseases that we already have developed vaccines for. Next slide. April 3rd, the president released his fiscal year 2027 budget request. This is just a request, so these changes are not implemented, but this is sort of an idea of where the administration wants to go with the federal government appropriations for next year. It overall cuts $5 billion to the National Institutes of Health, where they do tremendous research into diseases, cancer, early childhood care, as well as a multitude of other areas. It fully eliminates the National Institute on Minority Health and Health Disparities. It eliminates the Hospital Preparedness Program, which was a grant program for states and localities to help bridge the gap in their care. It eliminates the Center for Disease Control's core HIV prevention funding, which totals over $750 million, and cuts the Community Services Block Grant, which is another grant program to states and localities, by $775 million. So NCAPA, along with our partners, sent appropriations request letters previously to this budget, but when Congress was seeking those letters. And as Congress is now working through those bills, we're going to continue to stay on top of making sure that our priorities are funded and don't reflect the president's budget. For example, we asked for $27 million for the Native Hawaiian healthcare program, $35 million for culturally specific services within the Office of Family Violence, $225 million to the Division of TB Elimination, and then $11 million for the Minority Fellowship Program within the Substance Abuse Mental Health Services Administration. Next slide. And so finally, what are the impacts or projected impacts of these policy changes? Well, 64.5% of AA and HPI consumers who purchased healthcare on healthcare.gov chose the silver plan with cost sharing reductions. Those reductions are income based. And 20.8% purchased the lower monthly payment bronze plans. Those have lower initial costs, but higher deductibles generally. So we're talking about 85% of AA and HPIs who purchased either low payment plans or needed assistance in purchasing their silver plan. So without those subsidies and those increased premiums, we're going to see fewer people choose care. And this is in the middle of an affordability crisis, right? Where families are choosing between putting food on the table or purchasing healthcare. Nearly 28% of Asian Americans have limited English proficiency, and the Trump administration has also cut numerous programs across all sorts of agencies that support English learners and provide resources for LEP individuals. So that's one of the largest hurdles to procuring care, and it's just going to be even harder for those that need it and those that are vulnerable and need that care to actually be able to access it. There's been continued immigration arrests at sensitive locations, schools, hospitals, courts, and places of worship. And these aren't just pulling in undocumented immigrants. We've all seen legal immigrants and citizens be pulled into these arrests. And that just makes minority communities less likely to seek necessary care. It makes them less safe, less healthy, and it makes the broader community in which they live less safe and less healthy as well. And these health disparities we see will likely widen as programs related to addressing them are caught in the anti-DEI cuts. As I covered in the previous slide, a lot of the programs that were funded to analyze why these disparities exist and how to counter them no longer exist, at least in the president's budget. And look, there are over 1.1 million Asian Americans and over 63,000 Native Hawaiians and Pacific Islanders that have no health insurance coverage, and we're expecting that number to go up. And while the president's budget has continued to cut care in these areas, 70% of AAPI adults want to see the government spend more money on healthcare and more on supporting low-income individuals get the care they need. So with that, I'll go ahead and pass it back to Sina.
Thanks, Ravi, for sharing those updates. We'll now play a video from Representative Judy Chu. She shared some remarks. She couldn't be here today, so we thank her for showing up for our communities. And it may be a little bit hard to hear on your end, but if your volume is a little low right now, you might want to turn it up. Thank you.
Hello, I'm Congresswoman Judy Chu, representing California's 28th District, and I'm honored to join your discussion on the state of AANHPI health. I want to thank the National Council of Asian Pacific Americans for bringing you all together to discuss such a critical topic, because especially during Minority Health Month, we recognize that all communities experience health and our healthcare system differently. I was here in Congress when the Affordable Care Act was debated and ultimately signed into law, and I saw firsthand how transformative it was, especially for the AANHPI community who face some of the highest uninsured rates in the country. The ACA expanded coverage, reduced disparities, and made care more accessible and affordable for millions, including over 1.5 million AANHPIs who rely on it today. That's why I've spent my time in Congress fighting to protect it. During the first Trump administration, I fought against more than 70 attempts to repeal or weaken the ACA because I knew exactly what was at stake. But now, Trump and Republicans have continued this attack on our health care by eliminating the ACA's enhanced premium tax credits, gutting Medicaid by $1 trillion in their big ugly bill, and triggering the largest loss of health coverage in modern history. Millions of families are seeing their premiums skyrocket, and roughly 15 million people are being pushed off their insurance. That is simply unacceptable. But Democrats are fighting back. We forced a vote to extend those tax credits and were able to successfully extend them for 3 more years. And I'm continuing to push the Senate to extend these vital tax credits and doing everything I can to protect the ACA and make healthcare more affordable for every family. At this moment, when access to healthcare is at risk, advocating for health equity is more important than ever. The AANHPI community is disproportionately affected by hepatitis B, and just last week, when Secretary Kennedy appeared at the Ways and Means Committee, I confronted him directly on how rolling back the hepatitis B birth dose vaccine for newborns would affect us. Our community also faces difficulty getting access to care due to high rates of cultural health stigmas and barriers in language access. And that is why I was proud to reintroduce H.R. 3316, the Stop Mental Health Stigma in Our Communities Act, which would provide culturally competent educational and outreach strategies for our AANHPI community. Advocating for health equity fundamentally means advocating for those whose rights and voices are being ignored. And we are seeing the Trump administration's relentlessly attack our immigrant community members. Today, there are nearly 70,000 individuals in federal immigration detention, the highest number in our country's history. And this high number tragically corresponds to a high number of deaths, 47 since Trump took office again. These individuals are trapped in abysmal conditions and are often denied medically necessary care until it is far too late. And it's only getting worse. Why I will continue to fight to conduct oversight of these facilities, as is my legal right as a member of Congress, to demand answers, accountability, and transparency for those detained inside. And as House Republicans extend the largest partial shutdown in American history, I will continue to oppose any additional funding for ICE without any meaningful guardrails or real accountability measures. In my own district, it was only a year ago that the Eaton fire, the second most destructive wildfire in California's history, forever changed the communities of Altadena and Pasadena. Over 70% of Eaton survivors have still not returned home, and over half of the 6,000 households impacted haven't started the rebuilding at all. A healthy and safe living environment is critical to our overall health, but Trump and congressional Republicans are withholding Governor Newsom's disaster supplemental request. These funds and resources are critical for communities to return to healthy homes and healthy living, and securing it remains one of my top priorities in Congress. I hope today's conversation inspires you and your important work advocating on behalf of our AA and HBI community. Thank you all for what you're doing to make a healthier and more equitable future for all.
Thanks again to Rep. Chu for those important updates from the Hill, and we express our gratitude for the work she continues to do for our communities. We'll now hear about some data insights from Michelle Wong with AAPI Data.
Thank you, Sina. Okay, yeah, next slide. Okay, so yeah, I'm excited to share with you all some key findings from our By the Numbers resource guide highlighting NAPI views on healthcare. Next slide. So from our 2025 policy priority survey, we found that healthcare is a primary issue for NAPI families, with 41% of NAPI adults identifying healthcare as the most important problem they face. Next slide. So over the years, we've seen substantial gains in NAPI access to care. Since the ACA was introduced in 2010, the proportion of uninsured has declined significantly from 16 to 6% among Asian Americans and from 17 to 11% amongst NHPIs. Next slide, please. Although the uninsured rates have dropped among NAPI adults, it is critical to note that significant disparities still exist among subgroups, with Mongolian and Marshallese adults reporting the highest rates without health insurance. Next slide. However, the gains in healthcare coverage among NAPI adults may now be under threat as millions are slated to lose health coverage under the recent health policy cuts introduced in the 2025 budget reconciliation bill. Next slide. A bill that we found is largely unpopular among NAPI adults, with 55% reporting their opposition to a bill that would reduce Medicaid for low-income residents, even if it meant taxpayers save $1 trillion over 10 years. Next slide. In fact, when it comes to budget priorities, 70% of NAPI adults believe the government spends too little on improving the healthcare system. So I'll just say healthcare investment is definitely important for NAPI adults. Next slide. However, anxieties over healthcare affordability still loom large, with 40% of NAPI adults reporting little or no confidence that they could pay for an unexpected medical bill. And next slide. So for many NAPI adults, it is important that healthcare remains affordable, with 84% of adults supporting government regulations that place limits on the cost of medication, and 82% were supporting the government placing limits on the cost of medical care. Next slide. And the concerns about healthcare affordability are further reflected in marketplace enrollment trends. Here we have a little bit of older data, I think Robbie mentioned earlier. So now it is 65% of ANAPI enrollees selecting the silver plan with cost sharing reductions, which reduces costs when you get care, such as with deductibles and copayments. And then another 21% that Robbie mentioned earlier enrolled in the lower monthly payment bronze plans. Next slide. So yeah, this is just sort of a brief overview, but you can find more information on our By the Numbers Anapis and Health Guide, which covers API Data's public opinion data on healthcare, policy background, and also provides breakdowns on important health indicators such as chronic conditions, insurance coverage, disability, and more. So yes, we hope that this can serve as a valuable resource for your communities and your work, and thank you very much.
Thank you, Michelle, for sharing the numbers that reveal how our communities are thinking about health and healthcare. These data points help us to advocate for better policies on the Hill and educate AA and HPI and broader communities about the impact we experience. We'll now hear about some of that impact and what our members are doing to address it. Smira Khan joins us from the South Asian Public Health Association. Samira, at a time when information is accessible and can easily shape and influence health decisions, especially for first generation immigrants, it leaves room for misinformation and disinformation. Could you share insights into the unique challenges faced by South Asian communities based on SAFA's landscape report and examples of community-led solutions?
Zena, yeah, absolutely. You can go to the next slide. I think, yep, one more slide. Yep. So I think the key thing to understand is that in South Asian communities, misinformation isn't just about access to information, it's about how information is shared and who it comes from. So I'm happy to walk through what our report found and what we're doing about it. So this work is based on SAFA's landscape report on health misinformation in South Asian communities. Our work was supported through a small racial equity grant that we received with the help of NCAPA and the Tides Foundation. And we looked at how misinformation is circulating, what form it takes, how it's impacting health behaviors across the community. And then, you can check out the full report on our website. We also then developed some solutions for this issue. Next slide. So South Asian communities, especially first generation immigrants, tend to make health decisions through families, elders, community networks before even reaching out to a doctor, right? Especially those who are in the older generation. Community trust is very central to a lot of decisions that they make. But even with the younger generation, especially given all of the issues that we've been experiencing with changes in policy and health access, healthcare insurance, and whatnot, people tend to turn to their network, their friends, social media before they actually step foot into a doctor's office. So that collectivist instinct is, a really beautiful cultural strength, but it also means that when misinformation enters that network, it travels fast and it travels with trust attached to it. So a message from your mother on WhatsApp is going to carry more weight for some people than a CDC fact sheet. And they're also more likely to solicit that information from WhatsApp than to go onto the CDC's website and look for a fact sheet. So the platforms amplifying this, WhatsApp, YouTube, social media, may help our communities feel more connected, especially across continents, but they have very limited safeguards in place. And then on top of that, you're adding in language diversity, right? We are not a monolith. There's so many different, sub-ethnic groups within the South Asian diaspora. And so that diversity adds another layer to it because it weakens platform safeguards and moderation, making it easier for misinformation to circulate unchecked. And so then again, this diagram kind of just shows the different areas where misinformation is spreading and then how further it expands. Next slide. So one aspect of our project was taking a look at what the landscape of misinformation looked like on social media. So what we did was we scraped and analyzed nearly 300 posts on X using South Asian community hashtags over a 2-year period, and then randomly selected a subset of those posts to do a more detailed content analysis. What we found was that 30% of posts contained inaccurate information, with 22% of those posts being deliberate disinformation. and 8% were misleading by omission. What was also interesting was that a large portion of these posts that we had looked at, the misinformation was coming from news media outlets, including ethnic media. And then you could also, you have your bots and whatnot input in there as well, and a lot of paid accounts that were using X to amplify some of this misinformation. So that tells us that this is not just a health literacy issue, right? That we can solve by educating individuals. It's a platform accountability problem. The type of misinformation ranged from fear mongering about vaccine side effects to outright falsification about vaccine content. And none of the accurate health information was coming from health agencies or community organizations, and it wasn't being amplified in those same circles. You didn't see a post around misinformation being directly combated underneath it. So the information that's being put out there is not going to the same target audience. And so that gap is exactly where SAFA is trying to show up. So you can go to the next slide. And then another thing is that vaccines are just the entry point, right? So our landscape report documents that misinformation is spreading across multiple domains of public health. South Asian influencers with hundreds of thousands of followers on Instagram are promoting unverified supplement cures for chronic diseases and bypassing evidence-based nutrition guidance. There is now a rise in, I think, social media doctors who are trying to combat that misinformation, but the damage has already really been done with a lot of unverified, unchecked people who are spreading some of this misinformation. On mental health, misinformation often takes the form of discouraging therapy as a Western concept. There's a lot of downplaying around mental health issues. And again, none of this is coming from verified therapists or anything like that. It's a lot of unchecked misinformation that's being spread, which is very dangerous, especially in a community where 1 in 5 people will experience a mood or anxiety disorder in their lifetime, and where South Asian youth face higher suicide risks than any other minority group. On sexual and reproductive health, right, there's a lot of false beliefs that link HIV exclusively to the LGBTQ plus community that was being spread. And then the common thread really across all these different domains is that misinformation is traveling through a lot of the same channels where most of our community is present. People are on their phones, they're on social media, they're spreading this like wildfire through their networks, right? If it's being spread on social media, then it gets spread through WhatsApp to the older generations or to people who are in the diaspora. And that's what makes it so dangerous is it could just be one post, but then the way that it spreads, it's targeting a lot of people. Next slide. So what are we doing about this? SAFA has been partnering with community-based organizations to deliver culturally tailored mental health misinformation workshops in community and faith-based settings. We've been collecting surveys before and after the workshops to assess the effectiveness. So far, 59 participants have completed surveys before and after the workshop, ranging in age from 20 to 89. Before the workshop, 57% felt confident navigating mental health information online and approaching their providers. After the workshop, that number increased to 82%. 96% said that it was culturally relevant, and 96% would recommend it to others in their community. So we find that these workshops are, reaching the community where they're at these community-based organizations, and cultural events has been effective, and people are open and receptive to learning about how to combat misinformation. We've built on these workshops with a mental health misinformation toolkit that's really available on our website. And then we've also led a bunch of different advocacy workshops and webinars. Recently, we had one on combating vaccine hesitancy. We've also developed provider and community-facing resources that specifically target vaccine hesitancy in South Asian communities. The model is really simple, right? Trusted messengers in trusted spaces with content that actually reflects our lived experience, ensuring that we are tailoring everything to the community and using the same language that they use, right? Combating misinformation with that similar language. And so to scale this work, policy has to catch up as well. Next slide. So I think Kai had already put in the chat, but we are actually hosting a workshop right after this event at 2 p.m. today Eastern to address birth control misinformation in South Asian communities and discuss ways in which we can empower the community to advocate and advocates to combat misinformation. So if you are free, we encourage you to sign up for the webinar today. Next slide. And so then finally, from a policy perspective, there are a few key priorities that we are advocating for First, of course, is increasing funding for community-based organizations that are delivering culturally and linguistically tailored health misinformation interventions. We have the trusted relationships and the proven model, right? Everyone is going to their community centers, whether it's faith-based organizations, local community-based organizations. That's where you're going to have your best luck reaching the community. So it's not that we don't have the areas or the services. We have those relationships. What we do need is the resources to be able to scale the work that's being done. Second is holding social media platforms more accountable to combat the spread of disinformation. You do see now that there are these community notes that are put onto some posts that are inaccurate, but again, that's being fact checked by other community members, right? And a lot of this is not really culturally specific. So again, if we're thinking about language and the different languages that are being used to spread misinformation, the tools that are in place to combat that are not in place. And so we really need to start holding these platforms more accountable to stop the spread of the misinformation and disinformation. Third, as always, is disaggregating data, especially health data. We cannot accurately measure the impact of misinformation on our communities and health outcomes if we are invisible in the data. And then finally, expanding federal support for trusted messenger programs, right, in faith-based organizations and community settings that are specifically serving South Asian communities. Because again, we have these trusted messengers, it's the resources that they're lacking to be able to scale up. And that's really where a lot of the behavior change happens. So that's really all that we have for today. I know there's some links in the chat. Feel free to check out the reports that we have on our website and attend our workshop that's right after this. Thank you.
Thank you so much, Samira. Thank you for sharing the work SAFA is doing to address misinformation. Next, I'd like to introduce Angelica Cortez from Lead Filipino. Angelica, access to resources continues to be a concern for many families across our communities, yet Lead Filipino works to ensure those resources like testing and advocacy remain available. Could you tell us about your health equity programs and initiatives and its impact on AAPI communities?
Absolutely. And thank you, Sina. Thank you to NCAPA for the space. It's always a pleasure and delight to be alongside folks in this work across our region and our country. But I want to take a quick step back. I know I have about 5 minutes to douse you all with about a half decade's worth of Lead Filipino's journey. And I think it's important to tell this part of our journey because Lead Filipino, we are still small. We are as grassroots as they come. I say that we operate out of the trunks of our car. And we hold up our work in 3 main areas: health equity, which I'll speak about shortly, civic engagement and voter turnout, and grassroots leadership development. We are a full-time staff of 5, and we operate across San Jose and California. That'll be the bulk of sort of the origin in our current work around our health services, and Las Vegas and in San Antonio, Texas. So 2 significant polarities here when you look at California and the Medicaid program, and Texas having not expanded its Medicaid program. But I will talk about our community health workers and why that's important is if there are other small orgs on the line that are thinking through how to pair your policy advocacy with your direct services, we are living that right now, and we are making mistakes, and we are navigating these systems. So I invite that conversation if that's to be helpful to any of you, because part of weathering the storms that we're navigating right now are demonstrating that we are not alone in this work, and coalitions like NCAPA are important to have those conversations. So 10 years ago, we started out of San Jose as a voter registration project in front of Seafood City to get more Filipinas X's and O's to vote. And shortly thereafter, a few years passed, and it was the COVID-19 pandemic that really squarely brought us into a health equity conversation. As an organization that advances the social determinants of health and believes that for folks to be powerful and to build civic and cultural power, they need their basic needs met. We were sitting back and witnessing the disproportionate numbers of Filipina nurses who were working on the front lines, their COVID-19 related deaths in relation to the overall population of nurses and caregivers. So spotting those disparities, we also study our communities and need to recognize that 1 in 4 Filipinas X's and O's work on the front lines of healthcare, providing life-saving and life-changing services. So there were a number of flashpoints, and of course, the rise in anti-Asian violence and assaults that were happening in Santa Clara County, which is where San Jose is, 3 of which were tried as hate crimes against Filipina women of all ages. So there were these major points that then spurred the County of Santa Clara, the Public Health Department, to invite us to a conversation, which resulted in us helping to develop culturally responsive messaging to encourage that our communities get the vaccine. So you combine all of these influences and our advocacy with our members, that turned into our policy agenda around how are we providing services to our community members? How are we, and I loved the previous speaker, how are we enlivening being trusted messengers on the ground? How are we pushing back against isolation? There were high rates of stress and anxiety, much like we are facing today. And how are we translating what's going on in our communities directly to our youth and our families? So if we can go to the next slide, I'll talk about 3 areas of what we're doing. Thank you to the slide person managing the slide. So first, I think at every level, folks here on the line, we're tracking how cities are responding to the cuts of HR1, and at the county level and the state level. In Santa Clara County, where we provide our community health worker services, where we're looking at a $470 million budget deficit for just this fiscal year alone. And this county also, we approved to tax ourselves during the last special election to backfill. We are still making sense of what that means for our services. But we have 2 community health workers on staff because California, which operates the largest Medicaid program in the country and serves 1/3 of our population, 3 out of 7 kids are covered under Medi-Cal. We jumped at the opportunity to become a partner with a series of other AANHPI, CHW providing organizations in Santa Clara County. We did not know what we were doing. We went through the training, and now we are billing Medi-Cal for CHW services. So what does that look like? Our 2 community health workers are part-time right now. They completed their certification process, and we're serving about 30 to 40 families every month who are on the local health plan, but we're also taking referrals from nearby counties to provide resource navigation support, case management services, and referrals to mental behavioral health, pro bono legal services, immigrant rights services, just a true benefit to be in community with other providers that give these services. So our community health worker program is still being established. I think there are a lot of sustainability concerns just given the significant, not just the Medi-Cal reforms that predated the passage of HR1, but also how we will, at a local level, sustain given the cuts that are coming down the pike. Second is our health educator training, recognizing the pressures, recognizing the changing landscape. How are we also creating pathways for not just PhilAMs who work within medical occupations and healthcare professions, but also students, also seniors who want to be trained in community health work. So our health educator program called Kalusugan runs every June through August. It's an 8-week program. On the other end of it, you're receiving your certification in mental health first aid made possible by our partners, and with an optional pathway to pursue your CHW certification. Again, that is now an observable, reimbursable item through Medi-Cal. So we help with placements to get into that either 15 or 21-week certification program. Last year, we trained 11 health educators, and one of them is working toward their CHW certification. It's like a whole semester class. So we help with creating those pathways and fostering those opportunities. And then lastly, our Filipino cancer study. This was a 5-year-long endeavor, y'all. It started in the fall of 2020, one of those flashpoints that I mentioned in terms of certain institutions and systems finally taking a step back and saying there are real disparities impacting AA and HPI communities. And we're like, we've been knowing this. We partnered with Stanford across a 5-year endeavor and led the first Silicon Valley, Santa Clara County focused Filipino cancer study, recognizing again that 1 in 4 PhilAMs work on the front lines of healthcare. We are working on a publication right now to get this into the hands of our people, into the hands of our communities, to inform the growing body of literature, to inform prevention and intervention, program development and policies. And this study, when it is published, will be the 17th of global studies that have been done on Filipino cancer disparities. And I want to say that our study was modeled after the Cedars-Sinai Filipino community and cancer needs assessment. So it's nice to be in partnership with other providers across California. So we're still trying to figure it out. In some, we are providing services, we are learning as we go, and then taking what we're learning, observing, and feeling directly to our local policymakers and state legislators. And we do that through the good work of folks like NCAPA and other regional coalitions like AAPI Force that we are a part of. Will be at the state capitol in a few weeks' time. And then also with the Asian Americans for Texas table, as we prepare for the State House to reconvene in about 6 months, we will be preparing to defend funding for social services and to protect the most vulnerable in our youth and our families. Thank you again for the opportunity.
Thank you so much, Jill. Thank you for providing such important programs and services and working to advance health equity. Our next speaker is Tweety Fatuesi from the United Territories of Pacific Islanders Alliance, Washington, or Utopia, Washington. Tweety, we've seen that there are over 100 health-related anti-LGBTQ bills and policies from both federal and state governments across the country. However, Utopia continues to combat those harmful policies by being a safe space for a 2S LGBTQIA plus community, including your work through the Mapumaya Clinic. Could you share more about the services it provides and what you're doing to protect the communities you serve?
Yes, and before I do, I want to just express my gratitude to you, Sina, as well as NCAPA for inviting me to be a part of this conversation. I've been really thinking a lot about the question that you just asked, and there's so much that comes to mind for me when I think about this because I really took the time to just sit with the weight of what you had just named. And that is over 100 of those anti-LGBTQ policies both coming at the federal and state levels, hitting our communities from every single angle. And I think what's more important to understand is that these policies aren't just abstract policy fights. The number of the bills that's seeking to prohibit gender-affirming care, medical care supported by every major medical association has surged a lot in recent years. Particularly since the start of this administration. And so many of those policies are seeking to outlaw care for minors and adults and would otherwise impact insurance coverage and access to services. And so every single one of those bills has become an attack on a real person's ability to access care. Their ability to be seen, their ability to survive, right? So when we talk about what Utopia is doing to push back, I want us to understand that what we're doing through our work at the Mapumaya Clinic is not necessarily just a health program for us. That is our active resistance to all of the policies that's been coming towards us. So I want to take a moment to share a little bit about what Mapumaya actually is. Mapumaya is a Samoan phrase. It means to invite someone over to rest. And I think that is everything. In a political moment where our communities are being legislated against, even criminalized and told that we don't belong, Utopia has built a place and tells people a message to come here and rest because you're safe here. And so that is the ethos of the clinic that we've been able to build since 2022, when we launched our community health clinic. And so that is what it was designed to feel like from the moment that you walk in. And so again, Mapu Maya is a place of refuge, and it's aimed at providing the Two-Spirit LGBTQIA plus communities with quality healthcare in a space that honors all facets of our identities. And it's, again, a gender affirming and culturally aligned space for community members to receive the support and services that's congruent to their well-being. Now, let me speak about some of the specific services because I think the breadth of what the clinic provides is truly remarkable, right? Mapu Maya is a free clinic and is dedicated to connecting marginalized communities with quality healthcare, with the hopes that everyone, especially community members who are either uninsured or underinsured, is able to connect with a medical healthcare provider to get the care that they need. And all of this is provided either at free or no cost or no insurance required, right? And so I think that's very critical because um, we're now in a place where healthcare access is being weaponized against low income queer and trans BIPOC communities every single day. And that baseline commitment is everything. And so on the primary care side, community members can access Mapumaya Clinic doctors who are volunteering their time to be able to meet with community members at no cost to them. That's general health care, that's check-ins, that's wellness, right? And so that kind of foundational care is what makes so many queer and trans people of color it would either cause them to either delay or avoid and avoid seeking health care entirely because of the way that they've been mistreated or misgendered or dismissed in other traditional healthcare spaces. And so Mapumaya Clinic was built to be different in that way. We also provide full sexual health programs, giving community members the access that they need to a variety of sexual health support. A lot of that ties in with HIV, STI testing, naloxone care, or harm reduction care, electrolysis, and other care services. And we're in a time right now where a lot of those policies are actively trying to restrict sexual health education and access. And so for our approach, Utopia is doubling down on making sure that people have exactly what they need to be able to make informed decisions about their bodies. From a gender affirming care perspective, the clinic offers hormone replacement therapy, physician referrals, support letters, consistent monthly check-ins to be able to test for your hormone levels through blood draws. And I can't express how significant that piece really is because right now, with this administration, gender affirming healthcare is being banned, and it's critically affecting a lot of our youth, as well as the parents and the families that are trying to find ways to support their transitional journey, their personal journey, because that's a sacred journey, right, for all of us. And adults are being told that providing that care is illegal and that our lives don't matter right now. And so our approach to that, we want to make sure that we're standing right in the middle of that gap, making sure that hormone replacement therapy and the access to be able to secure doctor letters, the referrals, the whole pathway exists and is accessible to the entire community. I talked a little bit about naloxone access, but the clinic also provides a needle exchange service through the approach of harm reduction without judgment, because we understand that our community members are navigating multiple intersecting crises at once. And so meeting people where they are is really actually how you make that lasting impact. Beyond our clinical services, the community services program, beyond our clinical services, we do have a community services program where I have the honor of leading through our Food Access Network program, as well as our youth program. And so we all work together to provide either one-on-one case management support, connecting people to apply for insurance through the state, as well as connecting them to housing and employment, as well as food resources. But there's a whole lot more to that because once you make that connection, you end up realizing that you can't fully care for a person's health without helping to stabilize the other aspects of the conditions of their lives. So we treat those as health issues as well. The clinic also provides electrolysis services, and that's really great because we've been able to put a community member through the educational process to be able to get licensed to practice electrolysis or laser hair removal, if you will. And so that service has become an effective solution for those who identify as either trans or fafafine or vakasala to be able to be more affirmed in their gender. And so there's a lot of dignity behind that. And I'm really proud to be able to speak on that too, because the person that we've been able to support with their educational process to become licensed is a representation of our community. They identify as trans, they identify as fafafine. So we know how to be able to provide that service to community members who look just like us. And so again, in a clinical set, the clinic does not work specifically to create real safety for, it does work specifically to create real safety for queer and trans, BIPOC, gender diverse, intersex people, as well as our community workers, our sex worker community workers. And so in addition to that, there's also a cultural layer. Programs like our arts and culture that offer cultural competency, language revitalization, and decolonization practices working to reclaim narratives that bridge the generational gaps with our community members. And a lot of that is done through talanoa, which is a form of panel speaking or speaking with one another, as well as our Warriors of Wisdom support networking group, which is also a great aspect to our work. And so because Utopia was founded by women of color who identify as either transgender or fafafine, we approached this community work through that intersectional lens and that cultural lens. And I don't say that just as a talking point. That is in the DNA of every program that we provide here at Utopia Washington, and that includes the clinic. My own work with Utopia through the Community Services and Food Access Network program sits right along that commitment because mental health and community connection are all part of the same ecosystem of care that the Mapumea Clinic was built to serve. So when you're asking what Utopia is doing to protect the communities in the face of all of the over 100 anti-trans legislation policies right now, the answer is pretty simple. And I think that in response to that answer, we're building the infrastructure. We're building a place where someone can walk in uninsured, undocumented, Black, Brown, Pacific Islander, trans, queer, whatever their identity, whatever their lived experiences are, folks can receive real, free, and dignified care. And so the staff providing the services again, looks like them, understands their culture, and honors the fullness of who they are. And so the goal of the clinic is to continue to close that gap between healthcare services and the well-being of our community. And I think in this moment, that gap that we're trying to close is the critical survival work that we're trying to accomplish right now to be able to sustain our services going forward. And so, in essence, with all of that taking place in this time right now, Utopia is not flinching. We're still going to remain resilient to be able to provide our services and keep our doors open. And that's really all that we're doing right now in this moment in time to be able to operate and care for our community members. Yeah, and so I want to thank you for the opportunity and thank you for the question, Sina. And I hope that if anyone is interested in learning more, I'm happy to drop some of the information to our Utopia WA website. You're welcome to take a look and connect with us through there. Fafitai Telelava.
Tailava, Tweety for sharing the critical work Utopia is doing to provide safety and resources for the queer and trans community. Just doing a time check really quick. We might go over a little bit because I want to make sure we give the have enough time for our next couple of speakers to share their presentation. So if you could stick with us a little longer, that would be great. But we also respect your time as well if you need to hop off. Next, I'd like to introduce Sidel Barreto with the National Asian Pacific American Women's Forum, or NAPAWF. Sidel, we've seen that abortion criminalization continues to increase following the repeal of Roe v. Wade. Could you share some of the key findings from NAPAWF's report Beyond the Labels and what this means for AA and NHPI women?
Yeah, thank you, Sina and Kappa, for bringing us together and creating this space. I want to start by grounding us in what this moment looks like for many AAPI women and gender expansive people. After Dobbs, abortion in the United States has been increasingly shaped by criminalization, with laws that have expanded surveillance and legal risk around pregnancy outcomes. And we're seeing these policies intersect with other systemic inequities like racism, xenophobia, immigration enforcement, which disproportionately impact marginalized communities, including API populations. And so our Beyond the Labels report aims to center API experiences to reframe abortion as both a personal and community issue, while also highlighting the need for decriminalization and equitable access to care. Next slide, please. So our report is the first national mixed method study examining how AAPI women view abortion access within the broader context of immigration policy, healthcare exclusion, and abortion criminalization. And what we heard very clearly from our communities is that abortion is understood not as some abstract political issue, but as inseparable from economic survival, from immigration security, from family well-being, and freedom from state punishment. We also found that AIPI communities do support abortion access. In our research, 65% of AIPI women said that abortion should be legal and available. And when we frame abortion in terms of protecting people and their ability to make decisions about their own bodies, support goes up even more to 86%. And we also found that more than 80% of respondents feel that these decisions should be made without government interference. And so for API communities, abortion isn't necessarily seen as a political issue, it's seen as healthcare. Next slide, please. Where we are seeing challenges is around access to information and the impact of criminalization. Many respondents, especially those who live in states with abortion bans, didn't even know that those bans existed. And fewer than half were aware of laws that punish people for seeking or helping someone access abortion care. And this combination of rapidly changing laws, lack of in-language information, and misinformation creates real confusion, and that confusion can lead people to delay care or not seek care at all. Next slide. And then layered on top of that is what we see at the intersection with immigration. We found that 36% of AAPI women say that immigration status is a barrier to getting an abortion. 23% believe that it's extremely likely that someone could be detained or deported for trying to get an abortion. And 64% believe that detention or deportation is at least likely when seeking care. And so how does that translate to real life? It means that people are afraid to go to hospitals. It means that they're worried about interacting with any kind of system that might expose them or their families. They may delay care, have to travel long distances, or even just avoid the healthcare system altogether. And even in situations where enforcement isn't guaranteed, the fear alone is often enough to stop people from seeking care. Next slide. It's also important to name that abortion access doesn't exist on its own. It's shaped by a whole set of structural realities. Lack of insurance due to immigration exclusions, high out-of-pocket costs, housing and economic instability, and also stigma within communities. In fact, nearly 3/4 of our respondents identified that judgment or lack of support from friends and families is a barrier to getting an abortion, with 39% describing it as a major barrier. 60% said that it was difficult for people in our communities to talk openly about abortion. And so, even though family and friends are important and trusted sources of information, stigma and judgment also create a disconnect between API women's desire to discuss abortion and their ability to do so openly within their communities. Next slide. Finally, I just want to touch on what this means for policy and messaging. And we specifically looked at support for policies such as the HEAL Act. And what we found is that support is there, but it's not always super strong. And how we frame those policies really matter. The HEAL Act, or the Health Equity and Access Under the Law for Immigrant Families, would expand access to affordable health care by removing immigration-related restrictions that currently exclude many people from federal healthcare programs such as Medicaid and the Affordable Care Act. And this piece of legislation is really critical because it directly addresses one of the structural barriers that we saw come up in this research, that without insurance or affordable coverage, many API immigrants are effectively locked out of essential healthcare services. Our research showed that people tend to respond more positively when healthcare access is framed as inclusion or making sure that everyone is able to access the same systems, rather than something that feels separate or special. And across the board, we saw that the most trusted messengers are doctors, healthcare providers, and people who have lived experience. There's also a clear preference for in-language and culturally grounded information. Next slide. And so building on that, when we look more specifically at messaging itself across API communities, we see some clear patterns in what actually resonates and what doesn't. Across all of the groups we studied, family-centered framing is the most consistently effective. It's important to note that family, though, doesn't mean the same thing everywhere. For some communities, it's about care and protection. For others, it was about responsibility. And for others still, it was about making decisions that support long-term stability and future generations. We also saw strong effectiveness for rights-based and autonomy-focused messaging, especially among Chinese, Indian, and Korean women. These messages tended to land best when they emphasized freedom from government interference and the idea that these are very personal, private decisions. For Vietnamese and Japanese women, messaging that is more values-based and positive tended to resonate more, including things like dignity, safety, and protecting the next generation. And then lastly, Filipino women in particular had more mixed responses. Alongside family-centered framing, there's relatively more openness to messages that emphasize responsibility and moral reasoning compared to other groups. And across every community in the study, there's a consistent finding that messages that support punishment or criminalization of abortion are the least persuasive. And so stepping back, what this tells us is that effective messaging is not abstract or ideological. It works best when it reflects what we already heard earlier in the research, that real life decision making, trust in healthcare providers, and communication that feels grounded in people's lived experiences rather than politics or punishment. And I'll just quickly close with this. If we want to achieve health equity, we have to address the fear, the misinformation, and the structural barriers that are preventing our communities from accessing care. And so that means integrating abortion into immigrant justice work, expanding culturally competent outreach, and building systems where people can seek care safely without fear of punishment or exposure. Because ultimately, our communities are very clear about their values. They believe in dignity, autonomy, and care, and our policies need to catch up with that reality. Thank you.
Thank you so much, Sidel, for sharing about the report, and another resource that we can use to advocate and protect our communities. Our next speaker is Napua Caston Fisher from Papa'ololokahi. Napua, we know from a Native Hawaiian and also a Pacific Island perspective that the health of our communities is dependent on the health of our lands. With the recent flood on Oahu, could you share the impact on Native Hawaiians' health and what recovery efforts POL is undertaking?
Aloha and mahalo for the opportunity to speak here today. My name is Napua Caston Fisher, and I'm the Director of Community Initiatives at Papa'ololokahi. POL is the Native Hawaiian Health Board, and our mission is to improve the health and well-being of Native Hawaiians and their ohana here in Hawaii and on the continent. So here we are in Hawaii. We're 1 month out after the second Kona flood event. I'm calling in from the Moku, the land district of Waialua, on the island of Oahu. And I am a resident of Waialua. I'm a flood survivor of this current flood. And I will share our perspectives as a staff member and as someone with some lived experience. From a systems perspective, there's already talk and already language shifting from short-term, immediate response to long-term recovery. But for many people in the community and across Hawaii, that framing doesn't reflect our lived reality. Across rural areas on Oahu and the neighbor islands, many people are still very much responding to an emergency. We have farmers still clearing mud and debris and waiting for their water to be turned back on. Families are facing eviction or rent increases. Households have to live in the homes that are unsafe and growing mold, and communities that remain harder to reach because of their rural locations are unable to access their areas and infrastructure because it hasn't been fully restored. Recovery shouldn't move on a single timeline, and it certainly doesn't end when the floodwaters receded. That gap between how institutions describe recovery and how communities live it is where equity issues become most visible. During the Konolo flooding, health impacts showed up quickly amongst mostly minority communities across communities like Waialua, Ko'olau, Maui, Waianae, Molokai, and Kauai. Rural communities experienced slower emergency response, limited access to clinics and pharmacies and providers, and longer waits for debris removal and basic services. For non-English speaking communities, the challenge went beyond medical access. Emergency alerts, evacuation notifications, health guidance, and assistance forms were not always understandable or accessible or trustworthy. Some families hesitated to engage these systems that ask for personal information, and in those moments, access to clear and trusted information became just as important as access to care. We also saw the cascading effects of disaster on physical and mental health. There were interruptions to chronic disease management, respiratory issues from the growing of mold and contaminated environments, and deep fatigue and stress, especially for caregivers and organizers who are responding while dealing with their own losses. For many families, recovery became an ongoing source of harm rather than relief. Papaololokahi approached this response with a clear understanding that people living through a disaster understand it first and the best. And at Papaololokahi, in all things that we do, we try to move what we say at the speed of trust as often as possible, even though we know that in the moments of rapid response, time is limited and decisions sometimes have to be made quickly. We always want to center our decisions around community members. And the community that has the lived experience must always be brought into the conversation as soon as possible, and that their input and opinions hold real weight when decisions are made about their own communities. That principle guides our work throughout all things that we do, but also for the Kona response. Many of our staff members have been deeply involved in the Lahaina wildfire response, and those lessons carried directly over to Oahu in this moment. One example that we implemented in Maui and carried over here is what we call our Kopua binder, which helps survivors organize their important documents and resources and kind of consolidates the information that assisting organizations always ask for: contact information, address of the damaged location. And rather than saying the same thing over and over and getting fatigued with talking to these providers, community members can just hand over this this binder, and they can take the information out that they need. For the Kunalo response, the binder was adapted based on what communities here needed and how they were navigating their recovery. In Waialua, where I was born and raised and continue to live with my family, my work focused on staying consistently present and assertive, which for me as just myself, it's hard for me to be assertive. And I'm always a very quiet person. Sometimes I think it's due to my upbringing and culture, but many other factors. So it takes a lot for me to be assertive. But that meant that we identified the immediate needs by residents, supporting public health communication in accessible ways, and helping people navigate the community assistance center that was stood up by the city and county during a stressful and uncertain period. The work shifted day to day based on what people were experiencing and what resources were made available. We have supported what's called the Waialua Medic Hui by helping to create a standardized vetting process for medical volunteers from day one at ground zero till now. They continue to serve the community in a mobile clinic setting. The expertise from the Maui and Mauna medics help to guide this vetting process so that there was safety, certification, and accountability to inform the process. And Kapa'olakahi continues to raise issues around community data collection. We didn't want people to be taken advantage of in our community just so that later down the line, extractive data processes were used and people publish based on these vulnerabilities. So we wanted to hold accountable the organizations that were creating these needs assessments and wellness checks, making sure that they were responsible with the data and transparent with their use. One of the biggest lessons that we've learned is the role that community responders play in recovery. Our first responders really were farmers, truckers, heavy equipment operators, and if you folks have heard the news, we didn't have any city and county and state, well, we had very limited response from the government. And so our farmers and business owners brought their own heavy machinery out from their farms and their homes and started going out into the flooding waters, saving people from their homes, picking them up in the machine buckets and driving them over to safe areas for evacuation, moved cars, cleared debris, cleared the waterways in the dead of night. And we want to recognize the bravery of these community members and have that response be seen as a community asset and strength that should be rolled into future emergency responses as an essential disaster infrastructure. Most of these people out of aloha for community risk their well-being, their health, their livelihood to respond in that way during the floods and the many days following, so that we could start clearing out our homes and properties as soon as possible, even if our government wasn't quite supportive in those moments. So as we think about policy planning and practice, several of these lessons stood out. Disaster response is strongest when community members with lived experience shape decisions from the start, which I heard many people today talk about lived experience in their work. Rural and agricultural communities need sustained investment that reflects their realities. Language access and housing stability are core health issues, and community-based organizations and community responders are not supplemental supports, but they are foundational. At Papa'olakahi, our work in Hawaii and beyond continues to be grounded in lived experience and is always informed and guided by communities affected. Mahalo.
Mahalo nui loa, Napua. Thank you so much for sharing the stories and the impacts that communities there in Hawaii have been experiencing, and also the strength and resilience that that everyone has had, that it's what it took to, and is what it's taking to come together and show up for each other. And also those important calls to action as far as policy that you named. Hollow for sharing that as well and naming that. Um, I know we're a little bit over time, so thank you so much to our amazing speakers who continue to bridge these gaps, you know, and with such love and respect and care for all of our communities every single day. And thank you all for joining and staying a little bit over time with us. There's not enough time, you know, to share about much of the work that all of us are doing. So really just wanted to highlight, you know, our amazing members from the NCAPA Health Committee doing such critical work, especially during this time. Um, if you haven't already, please feel free to connect with us, subscribe to our newsletter, follow us on social media, and we'll also send up a follow-up email with the recording as well as the health fact sheet. Thank you, Alicia, for dropping those resources in the chat. Thank you so much, everyone. Take care.